everybody, my name is Manny and I'm here today with medcoach.tm, and today we're going to be talking about cellular adaptations. So cellular adaptations specifically are just reversible changes that can occur due to cell stress. And the key thing to remember here is that they are reversible changes. These are not irreversible changes. They can lead to irreversible issues. However, they start off as reversible. So if they are noticed fast enough, you can go back and fix them. The first one we're going to talk about is hypertrophy. So hypertrophy is specifically an increase in the cell size. So what this means is that it occurs normally in permanent and non-dividing cells. It can happen in other cells as well, but we usually look at permanent and non-dividing cells such as skeletal muscle cells or cardiac muscle cells for reference, because these are the cells that normally see an increase in size. You also will see an increase in protein synthesis. And the protein synthesis increasing is what causes for the cell size to increase. Pathologically, you can see increase in cell size when someone is exercising. So for example, in bodybuilders, you will see that their muscle cell size will increase. And then even in pregnancy, when women are pregnant, their uterus size increases, and this is their uterus hypertrophy. Then we also have pathological, a very key and important clinical case that you need to remember in pathological hypertrophy is left ventricular hypertrophy that happens because of aortic stenosis. This is when you see an increase in the left ventricle size, and this is a type of hypertrophy. Then we have hyperplasia. So hyperplasia often gets confused with hypertrophy, but something key that you need to remember about hyperplasia is that it's an increase in the cell number. Where hypertrophy was an increase in the cell size, hyperplasia is an increase in the cell number. So what this means is that it is unable to occur in permanent or non-dividing cells. And this is a really high yield fact, actually. I'm just going to double highlight it also in yellow. And the reason for this is because a question stem might ask you about a cardiac myocyte or maybe like a skeletal muscle cell that is undergoing an increase in size, or it's just gone through some sort of increase. And then they might ask you, like, did it undergo hypertrophy? Did it undergo hyperplasia? And this is when you need to remember that skeletal muscle cells as well as cardiac myocytes cannot undergo hyperplasia because they are permanent and non-dividing cells. So this is something very important for you to remember. I'm going to put a star beside it, that hyperplasia cannot occur in permanent and non-dividing cells. We also have, and this can happen along with hypertrophy, so it's not like just one or the other kind of has to happen. The only time that it will not occur alongside hypertrophy is when it's a permanent or non-dividing cell. And as I mentioned earlier, that's because hyperplasia cannot happen in those cells. So there are a couple of examples that you would want to remember. So there's breast growth during puberty. This is a form of hyperplasia. This is when the cells of the breast will increase in cell number. There's liver regeneration, which is again another important and kind of cool fact as well, that if, let's say, there's someone that donates their liver can actually regrow itself back. So this is a cell that will not normally be proliferating rapidly or all the time, but in the event that it needs to proliferate because of something, it can do so. Then we also have the bone marrow, especially in anemic patients. In patients that have anemia, the bone marrow will be proliferating. Also, in endometrial hyperplasia and in benign prostate hyperplasia. So these are two that you're going to want to be mindful of, because the prostate hyperplasia is benign, but the endometrial hyperplasia can lead to cancer. So this is something you're going to want to remember. And then, of course, a very, very important one is a malignant hyperplasia, in which you will have cancer cell formation. Then finally, we have atrophy, which can occur. Atrophy is a little different from the others because this is a decrease in the cell size or number, which results in a decrease of tissue size. So it can happen physiologically. This can be the uterus after pregnancy, the nodal cord, and even the breast at menopause. However, it can even happen pathologically, and this usually occurs because there's a loss of movement, so maybe someone on bed rest, there's cachexia, so someone has a loss of nutrition, loss of blood supply, and loss of blood supply is usually because of some sort of ischemia, and then obviously we have loss of innervation. So this is when the innervation to a muscle or a specific part of the body is lost, and this results in atrophy. So there are three main causes of atrophy, and these are very high yield, mainly because they also have a biochemistry connection, which you can see over here. So the three main causes is, first of all, there is a loss of proteins, and this happens via the proteasome and ubiquitin pathway. And then we have self-eating, which can also be called autophagy. And then finally, we have apoptosis. So these three are extremely high yield points that you want to remember that can cause atrophy. Then we can also talk about metaplasia. So metaplasia is when one type of epithelial cell transitions into another. So the first one that we want to talk about that's extremely high yield is Barrett's esophagus. Barrett's esophagus is when you have a regular stratified esophageal epithelium and it becomes columnar. Then we can also talk about smoker's trachea. Smoker's trachea is when the columnar or the tracheal columnar epithelium transitions into stratified. We have myositis ossificans, and this is when we have muscle mesenchymal cells that transition into bone mesenchymal cells. Myeloid metaplasia, and this is another high yield one that I want you to remember. This is when there is proliferation of hematopoietic stem cells that are in areas other than the bone marrow. This is extremely key to remember. It's other than the bone marrow. So it can be maybe in the liver, the spleen, areas like that. And then the last one that again is high yield and highly tested on is apocrine metaplasia. And the reason for this is because this is a benign metaplasia. So it's when lobular epithelial cells are altered, but it's benign. So it does not lead to dysplasia. So if we were to say that metaplasia leads to dysplasia, benign apocrine metaplasia does not lead to dysplasia. And then finally, we have dysplasia. So as I just mentioned, metaplasia will become dysplasia, and this is when the proliferation of cells is now disordered. So whereas in metaplasia, it was ordered, here in dysplasia, it's disordered. So you will see that cells will display pleomorphism. They will have abnormal nuclei, and you will also see mitotic figures. There are some risk factors that you're going to want to remember. And these risk factors consist of UV light, already existing hyperplasia, infections, and irritation.